And at the end of the meeting, we're going to ask you to complete a short feedback survey, if you will. Tell us, how we did today, if we answered your questions, if there's anything we missed, or if there's anything else you want to bring to our attention. So that'll be in the chat box at the very end of the meeting, and I'll call your attention to that. Next slide. So here's a picture of me and Dr. Esserman. I'm Steph Goodman. I lead marketing and partnerships for Wisdom. I'm located in San Francisco, and I've been with the study for 4 years. And I'm also a Wisdom participant. Proud to say I was a participant before I joined the study team. My mom is also a participant. And Dr. Esserman, our fabulous founder, is leading the discussion today. She's a director of the UCSF Breast Center, and she launched the Wisdom study and the I-SPY trials, among dozens of other fabulous endeavors. And we both have our blue shirts on in these pictures, so we match. Next slide, please. So the mission of the community forums is to move together toward equity, health equity, and better outcomes in breast cancer for everyone. And we have different discussions each month. They are usually directed by your feedback. You tell us what you want to learn about, and we get together our experts in the field and host discussions on these topics. Next slide, please. So this just lists the different things that we've discussed in prior forums. We've talked about health equity, breast cancer risk factors, clinical trial participation. The list goes on: nutrition, breast cancer across the lifespan, environmental exposures. We plan to talk about the use of AI in breast cancer research and mammogram reading. We also want to talk about data and health privacy in some upcoming sessions, and we'll ask you during this meeting today. We'll take a poll and see what you want to learn about for next month. Next slide. Thanks. So again, today's topic is about Wisdom 2.0, the new version that we've got launching, and we want to share with you our visions and our goals. And to start, we're going to have you fill out a poll. There's going to be a pop-up on your screen, and we want to understand what you want to learn about Wisdom 2.0 today. And here are the choices, because there are a lot of different features of this new iteration of the study. Very cool. Answers are rolling in. We've got more than half of you have answered so far.
And I'm excited to see that we have someone from Nebraska joining us. Welcome, Lynn. Exciting.
Dr. Esserman, are you seeing the poll responses?
I'm not.
Oh,
I will publish them in just a second.
Okay, they're almost like almost equal. We've got one winner. Okay, she shared results.
Okay. Okay. Well, I can make sure that I cover all of that.
And Sarah, can everyone see the results when you share them?
I believe so, but please let me know if not.
Okay.
I can.
Okay, great.
So Christine, I'll talk about, we're gonna eventually ask everyone to join 2.0. We're gonna slowly roll everybody over. Probably after 4 years of being in 1.0, you'll move over, but we'll see. I'll go over that, and I'd like people's feedback on that too. I was just sort of thinking about that.
All right, so I'll turn it over to Dr. Esserman.
Okay, we'll go to the next slide. Okay, so we are still in this period where people are feeling caught in the controversy, and there's been a new draft guidance from the U.S. Preventive Task Force guidelines where they said, well, okay, instead of starting everybody screening at 50 years old, we're going to start everybody 40 and screen every other year, which I'm not sure how much sense that makes, but that's yet another chapter in the controversy over breast cancer screening. So next slide. I think part of the problem that's sort of generating all of this is the guideline-based screening assumes that everybody has the same risk and that everybody needs the same thing and that every breast cancer is the same and everybody's at risk for the same kind of breast cancer, which of course turns out not to be true. So what we are trying to really figure out is how can we start with risk stratification where we can really look at finding the people with the very highest risk and then grading, with gradations of that down to, the lowest risk, where we can start to really hone in on the kind of screening that will help the people with the highest risk, which is not that many people, and really taking the people at the very bottom of the risk pool and doing less for those people. And I think it's important. Our study results will be out in about a year. The Wisdom 1.0 study results will be ready in about a year and a half. There's also a big study in Europe called My Personalized Breast Cancer Screening that actually was taking the people at the bottom 20% of risk and not screening them at all. So I think those two things are going to be super important for us. That may be something that influences what we do with this lowest group of women at risk. We shall see. Next slide. And again, this is about trying to say, we've got these fast-growing cancers. If you're at risk for a fast-growing cancer, screening every other year isn't going to help you. I'm not even sure that screening every year is going to help you. I think that screening every 6 months for the very fast-growing tumors is the right thing to do. So we've got to figure that out because we don't want to over-screen people unless they really have that risk. So we want to be careful and make sure that we know who those people are. And we'll talk about that. And the people who are going to have some of these slow or many of these things may not even go on. Now, this whole idea of stage 0 breast cancer or ductal carcinoma in situ, which I consider more of a risk factor for breast cancer, because it by itself isn't going to kill you and it may or may not ever progress. And so the thing that we've got to be careful not to do is to treat everybody the same. And people hear the word cancer and they get really freaked out and then they want to be super aggressive about it. But everybody doesn't need the same aggressive therapy. That's just one of the things that we've learned. There's slow-growing cancers that are better treated with hormone therapy. There are fast-growing tumors that really need chemotherapy and respond to chemotherapy. But, I can see a day where the way in which it's going for cancers that are HER2 positive, that the kinds of treatments that we are testing in trials like I-SPY are so easy to take and may be so successful, it may be something that we don't need to worry about screening for. It's really, I think that might happen in the next 5 years. That really is very exciting. Now we just have to catch up on every other subtype of cancer. Okay, next slide. Stop, and anyone who has questions, stop me as I go, okay? Okay, well, who gets breast cancer, right? You guys all know that. It depends on a whole bunch of things. Family history, breast cancer, and sometimes that's your genes and sometimes it's not. We don't know every genetic trait that is responsible for predicting risk, although we certainly know that there are about 9 genes that really contribute to people having pretty high risk of breast cancer, and that there are some genes that sort of contribute to the sort of intermediate risk of getting breast cancer but interestingly, we know what kind of cancer mostly that people get, so that we'd want to focus in on prevention. If you happen to have had lots of biopsies or your breast tissue is very dense and it stays very dense, those are risk factors for sure. Your age is a risk factor, but it's mostly that as you get older, the more people tend to get breast cancers, but they tend to get more of the slower growing cancers as they get older. So it's not all the same. The fastest growing cancers are more likely to happen to younger women, but you can get any kind of cancer at any age. And so it again depends on, all those genes that you inherit, a lot of whether you've taken hormone therapy, what kind of reproductive history you've had. So there's lots of pieces that comes together. Now, Kristen asks the question, how's risk determined? You know, she didn't have family history. She didn't have any known cancer predisposition and got diagnosed with a, what happened to that? And got diagnosed with a grade 3 invasive cancer at age 32. So, you know, that's one of the things that, you know, we are trying to sort out. So I'm going to get to that there are at least 2 ways that we can figure out who those people are. And that's looking at one of these 9 genes or looking at all of the other genes you have. There is, of course, we're not going to be able to explain every single person. But if we keep learning and we keep trying, keep trying to improve, the chances of, Kristen, someone like you being able to be diagnosed out of the blue like this, hopefully will be less and less. And this is the reason why, as I'll get to later, we are lowering the time that we start doing this genetic testing to 30. That we want to start at age 30 to find the people who have these inherited mutations or have the so-called many genes that come together. We call that many polygenic gene risk, polygenic risk. It gives us a clue so that we would know to screen someone like you more frequently. And I hope you're doing well. Anyway, that's the whole idea here. So we'll keep, and we're going to show you some of the findings from Wisdom 1.0 that's sort of leading us down this path. Neat. Keep going here. Next slide. So, you know, one size doesn't fit all. We don't, you know, nobody gets the same bra size, you know, I mean, goes out and buys the same bra. Everyone doesn't do that. And everyone has different body shapes. Our biology is different. Our breast cancer is different too. And we think our screening should be too. So the whole idea behind Wisdom 1.0 was to try and start down the path of saying that we can make a more personalized way of approaching this and do a better job, and at least find some of the people at highest risk and maybe reduce some of the burden of screening on the people at the lowest risk. And that was the whole idea. What we have learned is that maybe we haven't done as good a job at really trying to find the aggressive cancers versus the less aggressive cancers. And that's the work we're starting in Wisdom 2.0. One thing that's been super important to us is to make sure that our population is diverse, because we learn from everyone. We know that African-American women have a higher risk of it getting triple negative breast cancer up till 65. All young women have a higher risk of getting triple negative cancer until about age 40. And then it's much lower, except for African-American women. So again, we're trying to figure out if there are ways based on ancestry that we can try and predict who's at risk for these kinds of cancers. And we really want to try and focus more on prevention, at least applying what we know and trying to figure out some new approaches and new ways of making a difference. Okay, next slide. So this was the idea of Wisdom 1.0. Was it a safe? Which it looks like it is, because we haven't been stopped. Does it reduce false positives and the number of biopsies that people get? We don't know that yet, but hopefully in a year we'll know that. Will it encourage women to take prevention, which so far we do know that. We've probably doubled or tripled the number of people, but it's still much lower than it should be. And part of that is that I think we're not making the handoff to women's primary care physicians. It's really interesting that in the women, we, you know, as you know, in Wisdom 1.0, we randomize women to annual screening versus personalized screening. And we were told before we started that, first of all, that no one would choose randomization and that no one would choose the personalized screening arm. Both of those things turned out not to be true. And 60 to to 65% very consistently over the course of the trial didn't really know and were willing to be randomized because they didn't know which was best. And of the people who chose, interestingly, almost everyone picked the personalized screening arm. And it didn't matter whether you lived in Nebraska or South Dakota or California or Alabama or Washington, D.C., wherever you were around the country, about 85% of women wanted the personalized approach. So I think that shows that certainly it's more acceptable. And so, when I say, is it a better value, meaning for the people, we don't want to do a bunch of extra stuff for the people who are at lower risk, because that extra stuff is extra biopsies, extra exams, co-pays, things that if you don't need it, you don't want to do it. But we really want to be able to do more for the people who need it and less for the people that don't, and have the same good results for everybody. So next slide. So this is again what Wisdom 1.0 was, and it was women 40 to 74. And again, this is still true, no personal history of invasive cancer or DCIS. And everyone's eligible regardless of your health insurance status, and we cover the cost of the genetic tests. Next slide. The beginning, we were trying to get companies to do that, but that just turned out to be too hard. So we gave up on that for at least for a while, just for a little while. So this is our timeline. So we started Wisdom at 2016 at some select University of California sites, and then we expanded to Sanford in the Midwest, and then we expanded nationwide, and we removed the insurance requirement, and we opened specific sites to really improve the diversity of our enrollment. We included the VA in 2021, and we ended our registration for Wisdom 1.0, and we are just starting. We've just opened up our registration to women 30, and by the end of the year, we'll have Wisdom 2.0, and all of these women will be re-invited to join, and every year we'll be inviting everybody. So after you've been in for at least two screening rounds, everyone's going to be then asked if they want to stay and join Wisdom 2.0. So next slide. And again, one of the most important things of anyone who's participating in the study is just to keep in touch with us and make sure that you let us know if you wind up getting a biopsy, or certainly if you're diagnosed with cancer, because that's how we learn. That's the only way that we can figure out what's going on, right? So, okay. Someone asked how many women are in 1.0. So 45,000 women have completed Wisdom 2.0. About 55,000 women signed up, but 45,000 women have finished all the pieces and are still applying. We want to get 100,000 women, another 50,000 women to join and keep everybody in our cohort. And then we'll really have the power to make a difference. So we're super excited about this. And we want to add some new and exciting things depending on how much everyone else is looking for. So what are some of the things that we learned? We were the first to offer population-based genetic screening. I mean, getting out there and letting people get their genetic tests. A lot of people were very worried about that and thinking that we shouldn't do that, that would scare people. But we did a lot of work to try and check to see whether we were causing anxiety, and we haven't. It turns out that having a mutation, an inherited mutation for breast cancer, is not very common. And, if you kind of overtrain and overteach people, most people aren't going to pay as much attention until they know they have it. And we have plenty of time to educate women when they actually have a mutation, and that's worked out pretty well. But it turns out that about 60% of the women in Wisdom who completed genetic testing and had a breast cancer mutation didn't actually have a first-degree family relative with breast cancer. Now, part of that is because people often think about this as that's my mom's, it's my mother, my sister, my grandmother. And we need to know what's on our father's side. Families can be small, can have lots of boys in the family, and so you may not know because you may not see it. Some people do not know their family history. Some people are adopted. So there's lots of reasons why that can be true. But what that made us worry about is that doing a family history assessment is sort of the way that we've been thinking that we should be doing genetic testing. And that turns out probably not to be such a good idea. So that's really important for us. That's another really important reason why we want to think about doing things differently. And it turns out that if you have a mutation, so if you have one of the really high risk mutations like BRCA1, BRCA2, or PALB2, we actually want to find you at age 30, not at age 40. So that made us think, well, you only have to do the genetic testing once, and that we should really be doing it early on and making sure that no one has that. And the other thing that we can do is we can look for these polygenic risks. So looking at the many genes that you inherit, most of them don't have on their own, don't have a lot of impact on your risk, but taken together, we're starting to learn that there are groups of maybe 300 genes, and they're different if you're Asian American or Latina or African American, how much they can contribute. But we're learning a lot. There is now a scale or a polygenic risk that predicts for hormone negative breast cancer, or we've now broken it up into fast growing and slow growing, because there's different things that you would be thinking about, right? Fast growing tumors, you want to screen more frequently. Slower growing cancers, you may not have to screen as often, but you also want to think about prevention. We have lots of good tools that we can use to reduce breast cancer risk. And we know a lot about the hormone positive, which are the slower growing tumors. And we know a lot about how to reduce that risk and cut that risk in half. So we think that's very important too. Now, it turns out in screening, the majority of cancers that are detected are lower in grade. From another trial that I run, the I-SPY trial, where I'm dealing mostly with aggressive tumors, like the one Kristen told us about, most of these tumors are found by women themselves, and we're not doing a great job of finding them in screening. So we've got to make a change here. If we want to say early detection saves lives, then we've got to figure out how to make that true, because it's not exactly true today. So we want to find these women and improve screening more. Okay, next slide. So this is just a different way of looking at it. So it's not very common to have a mutation, but if you happen to have a mutation, most women don't have the family history that would make you say, oh, aha, I'm going to go out and get you screened with a genetic test. So we think we've got a test that's less expensive and easier to do than a mammogram. We should just be in the business of getting out there and doing it and understanding. So it's got a simple test to find these errors, which are not common, about 1 in 40. But it's critical, and we should start looking at age 30. The other thing that's important is there are 9 different genes. Some of them are very different. A BRCA1 patient is going to have mutation carrier is likely to have a triple negative cancer. A BRCA2 is more likely to have a hormone positive cancer. A CHEK2 carrier, not as high risk, but almost always going to develop a hormone positive cancer. It may be the most important thing that you can do is to get someone like that to take risk reducing medications and drop that 40% risk to like 20% or 15%. That's really what's critical. So at the very least, we want to start putting what we know to work. Okay, next slide. Okay, so what are we trying to do? So we're going to try to use our knowledge of breast cancer biology. And again, we started kind of simply saying, okay, we've got people who are at risk for the slower growing subtypes and the faster growing subtypes, because that sort of will help us figure out when to screen, how often to screen, and with what modality, because then we can also look at how dense the breast tissue is. We can sort of make these adjustments. But also, think about, again, what can we do about reducing that risk and making it about prevention? The other thing that it's helping us do is expand to this larger library of genetic information. So we've gone under a big transition. So we used to look for these individual genes and measure them, but now there's a better way where we can look at what we call take a low pass across the whole genome. And that gives us access to millions of these single nucleotide polymorphisms. And that allows us to kind of take advantage of and consume all the new information and all the new models that are being developed, which is very exciting. And another thing it's doing is we are working on using artificial intelligence with mammography. We're working with the people who are developing the tools to say, well, how can we take advantage of the other information that's in your mammogram, not just whether or not they see a cancer. So that's exciting. As we said, we're gonna start at 30, and a lot of the women who screen under that probably won't start till they're 50, but at least we'll find those high-risk people at a time where we might make the biggest difference, because a third of the cancers and mutation carriers happen in the 30s. We've gotten rid of the randomization for this portion because we really want to focus on getting the risk assignment right and show that we can do that. So if you're 40, you can choose whether you want to get annual screening or you can be in the personalized group. So you get to choose. Next slide. So this is just a little bit more of that same thing. These are the 9 genes and all of these different SNPs. If you happen to have one of these 9 genes, depending on what you have, you'll be told to screen either at 30 or at 35, or maybe you'll start risk reduction medications and then start screening at 40. So all of that. And there are new models. This is the Breast Cancer Surveillance Consortium model. There's a new version coming out in about a month. We're going to apply that. We actually have lots of exciting new models that we ourselves are also developing, which is the risk for fast growing versus slow growing cancer. So over the next year, we expect to be able to bring that in as we start transitioning more and more of our patients who've been in Wisdom to Wisdom 2.0. Next slide. So who can join Wisdom 2.0? Hot off the press as of last week, any woman between 30 and 74 who does not have a personal history of breast cancer, who lives in the US and has not had a prior double mastectomy. You have to have tissue that can be screened. And in early next year, we're going to start transitioning women who have been in the study to invite them to participate in Wisdom 2.0 as they transition off, and especially as we start to really integrate more and more of what we learn. We want to eventually get everyone transitioned over. Let's see, next slide. Okay, so we're going to stop for another poll. Now you're going to see another question. So we want to find out what you're excited about.
And Dr. Esserman, while they're doing the poll, take a look at the chat. There were 2 really important questions that rolled in.
Okay, okay. So do I recommend vaginal estrogen for 55-year-old menopausal women with a family history of breast cancer and check 2? That's such a good question. I think if you're on baby TAM, which is the 5 milligram, the low dose, probably what I would recommend is something called Estring. It's a little vaginal ring that you can insert that, or Vagifem. It's a really low dose and it really only affects the vaginal epithelium. So it really doesn't, you don't get a big absorption of estrogen. So I think that is fine. I'm hoping also that we also, by the way, have a study for women who are postmenopausal or haven't had a period, who are 45 to 65, who have either hot flashes or anything. We are testing one of the medications called Duave. It's a SERM. It's a fourth generation, what we call SERM, like tamoxifen, with a little bit of estrogen in it. And we think actually this combination will be risk reducing and be much easier for people to take. So if you think you're at risk and you live in the Bay Area and you are interested in being part of this study, let us know. Because these are the kinds of things that we want to try and study. Can we get people onto medications that balance the risks and benefits, so that I think people will be much more interested in prevention. I wouldn't say no vaginal estrogen. I would say I would use tools. I would use vaginal estrogen that doesn't get systemically absorbed. But I think it really depends. I'm never an absolutist. I always look and see what's going on with each person. You should sit down and find someone who will be flexible and talk to you about what to do. Let's see. The genetic counselors I spoke to didn't know people with TEC2 mutations likely have hormone positive breast cancer. Well, they are almost all hormone positive. Yes, so our genetic counselors that we use all know that, and I hope that wasn't one of our genetic counselors. If it is, let Stephanie know. But we do. That's one of the reasons we're excited about it. That probably the best thing you can do for a TEC2 carrier is put them on baby TAM, and that's a lot of people don't like taking tamoxifen, but these lower doses really have made it so much more tolerable. And I think it's so much easier for people to do things that can actually reduce their risk. So that's important. Okay, are you ready to show us some data? Sarah, are you ready to show us data? Okay, here we go. Okay, so people are excited about the updated risk models, the enrollment of women 30 to 39, better genetic analysis, and some interested in the ability to choose the arm, but not as much as the others. So that's very interesting. So that's good. All right, so let's see what else we have. I think we're going to give a few examples of how
Actually, I'm sorry to interrupt you.
Sure,
Laura.
Kim.
It's Kim.
Of
But
course.
Marianne has a question in the chat a couple times, and I think
I missed it. Where is it?
It's
Go
why
ahead.
are you limiting to age 74?
Oh, why are we? Oh, so that's another good question. So the question about when to stop screening is another really important one. And there's, again, a lot of controversy over that as well. The data suggest that as you get older, the chance of finding cancers, let me see how I can explain this. So there's a recent article that was published that I thought was very compelling, and I think that's one of the reasons why we have not extended the study out longer, is that the older you are, the more chance you have that screening will find cancers that aren't necessarily going to grow and progress. Remember, we had those slow cancers, so much so that by the time you're 80 to 85, 50% of the cancers that you might find aren't going to be the kinds of cancers that will kill you. And about 75 to 85, maybe 40% of those cancers. If I felt that people really, as people get better and better at not over treating people once they get the cancer, so that you say, oh, this is a small little cancer, it's not going to kill you, we'll just, cut it out, no radiation, and not over treat, that will make it easier to extend. But I think it's really much better to have it be very much more personalized. And I think that there are harms to screening, and those harms of screening increase as you get older. Does that explain? And Marianne, if you don't understand that, please ask. I mean, it is true that it's much more common to get cancer when you're older. But it turns out that, a lot of the cancers that we find can be, if you have a cancer that's 2 centimeters or 1 centimeter, your outcomes will be more the same. They're slower growing cancers, they're easier to treat. And most people are pretty aware. That isn't to say you should be aware. And if you have something that you find that's different, everybody needs to know that. Mammograms are by no means perfect. And if you find a mass or you know your breast pretty well, which everybody should, if you find something new that's different, you should bring it to the attention of your physician. Because 50% of women actually find their breast cancers themselves. So as long as you're being aware and you're finding things, that the question of screening is not, is really, does finding the cancer earlier make your outcome better? And do you do more good than harm? That's the goal of screening. That's sometimes a hard thing to understand. Does that make sense to people? Kim? Any comments?
Can you repeat that sentence?
So I said that, the whole goal of screening isn't just to find cancers, right? Because remember, screening for cancer doesn't mean that if you have a screen detected cancer, that means your life is saved because it was screen detected. What we know is we can reduce the chance of dying by a relative risk of about 20%. But as you get older, the types of cancers you get tend to be more of the slow growing cancers, not always, but also there's a reservoir of cancers that we can find, and we will find more cancers that maybe would never have come to clinical attention that then get over-treated, and people get more aggressive therapy that they don't really benefit from. Does that make sense?
So that means, for example, lives don't get extended. You don't have a better quality of life in
That's
those
right.
extended lives. Okay, got it.
That's right. That's right. So you really want to be thoughtful about when you're screening, and we always say to people that unless you have at least a life expectancy of 10 years, you should not be screening. And I mean, that's the other thing, is like, we don't want to be finding DCIS in someone who's 80. I mean, I don't want to know about that.
And what you're saying, you don't want to know about it because what you might do for it if you were to be aggressive may not actually add value to that person's the rest of those years. Right.
You're frightening somebody, make them think they have cancer, make them worry about dying of it.
Yeah. But I think what's tricky is just what's tricky is just the word cancer, because no matter how old you are, if you hear that word, you're gonna want it out of your body yesterday. So I think that it's a tricky conversation, and it's sort of saying we're not looking, or we're not trying to look at in the advanced stages, because we may not be able to do something to help you have a better life. So we're almost wanting to not, as you said, you're not wanting to find it at that age. But that, again, because it's cancer, sounds weird to people. And I don't think we're there yet.
Go back to that slide at the beginning, way back at the beginning about with the fast growing, all the way back to the very beginning. Way, way, way back. Yep. Go forward. Okay. So there are, believe it or not, there are these different kinds of cancers. So DCIS might be one of these, or there's actually these very extremely, what we call them, ultra low risk cancers that either here or here, and they're so slow growing, they may never come to attention. And certainly someone who has like high blood pressure, who's had a heart attack and had other things, then that's probably something where screening is not going to wind up adding a lot of value. It'll add stress. Sometimes I think it is, as Kim says, it's a tricky thing. When I am successful at changing the name of ductal carcinoma in situ, or these ultra low risk cancers, then I think it's okay to screen, because if people understand that what's being taken out isn't so-called cancer. I can give you another analogy. When we were screening for cervical cancer, we used to call cervical carcinoma in situ, that's what we called it, carcinoma in situ. But what was happening was that women were getting hysterectomies when they were in childbearing ages that they didn't need. So they changed the name. It's now called CIN, cervical intraepithelial neoplasia, or CIN. But CIN sounds a whole lot less scary than carcinoma in situ. And it really stopped that. So when we can change the names of some of these things, it may be better. I think it's one of these things that, Like we want to focus on these kinds of cancers and these kinds of cancers. This is where we're going to make a difference in, in someone's outcome, where getting it earlier is going to make a difference. These very slow growing cancers, if you found it here versus, here, by the red line or maybe a little bit later, the treatment was likely to be the same. Your outcomes likely to be the same. So it's not clear how much benefit screening has. Now, this is an area of big controversy. And, maybe it's something that we are going to start making more recommendations to the people in the study about how long they should screen. So once you're in, if you happen to still have a lot of risk, that we may screen you longer, as long as you're healthy. Whereas if you have super low, if you don't ever have the risk of even the average risk of a 50-year-old, it's not clear that you should be screening. Certainly shouldn't be screening over the age of 70. So those are the kinds of things that, if you think about it, we do this with colonoscopy. When people come in, if they don't have any polyps, we tell them to come back at 10 years. Whereas if they have a polyp or two, they'll come back in 5 years. If they had a lot of polyps, they'll come back in a year or two. And if they have tons of polyps, they'll come back every year. I don't hear anybody saying, oh my God, why can't I have my colonoscopy every year? And people don't even love their mammogram. So we're just trying to catch up, and try to make things, I see Kim crying, laughing. Anyway, but, we really are already thinking about that in many of these cancer detection things. So it's tricky. It is tricky. And it's tricky to explain, but people are so frightened of breast cancer. And believe me, nothing could be more important. I've devoted my entire life to breast cancer, but I want to do more for the people who need it and less for the people who don't. So that's the idea. So good question. Thanks, Kim. All right, fast forward.
We're gonna go through the personas, the examples of younger women who might enroll now, and what it would look like if they did. These are examples. All right, so here we go. So this is Jessica Rutherford. She is 33 years old. She's an artist and lives in Alabama. And this is why she joined Wisdom. She said, my sister was just diagnosed with breast cancer. Everyone has different recommendations for screening, and I heard that Black women should start earlier. I want to know more about my personal recommendation. Her sister I'm looking at the green part of the screen that shows her family health history. Her sister had breast cancer. Her grandmother had it, but the age is unknown. Her sister had it 39. She thinks that her breasts are heterogeneously dense. She's had no prior biopsy, but we don't know if she's had a mammogram yet because she's 33 years old and they probably didn't have she probably wasn't mammogrammed, but she was found to have a mutation through the Wisdom study. It's a high risk mutation. So Dr. Esserman, what would we do for Jessica?
So a woman like this is going to be recommended to get an MRI alternating with a mammogram every 6 months. So women with PALB2 mutations tend to get fast-growing tumors. And they're a mix of hormone positive and hormone negative. But when they can grow very fast. So screening every year is probably not often enough for someone like this. And so we know, right? And, it's interesting, we've heard on this particular forum, people being surprised that African-American women can inherit genes like BRCA1 and BRCA2 and PALB2 or things like that, but in fact, they can. And this is really just about, your genes are like ancestry, right? And so we would have her meet with a genetic counselor to talk about her risk reduction strategies and on that screening. Now, there are some women, again, and it really depends on everybody's individual, inclinations, but, people with BRCA1, PALB2, BRCA2, depending on whether people are really, when they get cancer, if they do poorly in the family, they, may decide that they want to get prophylactic mastectomy. It's interesting that we have now medications that can specifically treat these kinds of cancers. So I am hoping in the next few years that we'll have medicines that are not chemotherapy that will successfully treat these kinds of cancers so that people won't feel like they need to get prophylactic mastectomy. We're not quite there yet, but we're pretty close. And I'm hoping that with the ability to identify people early, that we might even be able to do some prevention studies to really, get people something better. That may be enough for someone to say, well, okay, I don't want to do anything too drastic yet. Or someone else might say, you know what, I'm sorry, I just watched what my sister went through. I'm not doing that. So that's the kind of conversations that we have with people, and we want to make sure that we give them all the options. Okay, next one.
Okay, this is Hannah Kwan. She's 35 years old and she's a nurse from Fresno, California. She is Asian. She has a mom who had breast cancer at the age of 75. No other family history. She has not had a mammogram yet and has never had a biopsy. She joined Wisdom because she said she learned about the study through a doctor. Her mom was diagnosed at age 75 and wanted to learn more about her own risk. She enrolled in Wisdom and does not have any genetic mutations. What would we tell Hannah?
Well, for Hannah, there isn't any particular reason for us to believe that she would need to get screened before 50 at this time. I mean, over every year we'd have her check back in and we'd rerun her history, but it may be that she doesn't need to start screening till she's 50 and that she could screen every other year. It's interesting, the United States is the only country that screens every year. Every other country looking at the same data screens every other year. And actually the UK screens every 3 years. And we all have very similar results. So that's what we would tell Hannah. So she's the kind of person who is likely to come back to start her screening more at 50. This is what the old US Preventive Task Force guidelines would have suggested and probably would do fine. And it's important because the highest rates of false positives come for women in their 40s, and nobody wants to get called back in and get a biopsy. And if you screen for 10 years every year in your 40s, you have a 50% chance of that happening, even though it's highly likely that it will turn out to be nothing. So that's something that we could spare her from safely. That's what this is all about.
And just to clarify that, we might recommend that she doesn't need to start screening until she's 50, but we would want her to continue to fill out her survey, her Wisdom Study annual breast health questionnaire every year, because risk is dynamic, it changes. Maybe someone in her family may have had a change to their health that could potentially impact her risk.
Exactly, yeah. And might have gotten breast cancer, so that might change our recommendation. And I noticed actually there's a question Marianne said, if you turn 74 while you're in the study, do you become disqualified and unable to continue? No, once you're in the study, you stay for 5 years. You might not like our recommendations, but we hope you will. And we might, that someone in the study who is, we think, higher risk, we would recommend to continue screening, so. Okay, let's look at our next person.
Okay, and by the way, we have 5 minutes left, so I'll read this one, and then Dr. Esserman, if there are other things that you think we need to touch on.
No, I think they're good. We'll try and get through these.
Okay, so this is Maria Rosa. She's 31 years old. She's a journalist from Miami, Florida. She has Hispanic background. She doesn't know her family health history. She enrolled in the Wisdom Study because genetic testing isn't covered by her insurance, and she wanted to learn more about her risk. She learned about Wisdom when she was researching free genetic testing online. She found out through enrolling in Wisdom that she does have a moderate penetrance gene mutation, a CHEK2 mutation.
So Maria Rosa has a CHEK2 without family history. So she is, this is something where we would probably think about screening at 40, but probably more important, we might want to talk to Maria Rosa, depending on whether she's had her children or whether whether she's planning to have children. I mean, the other most important thing we could do for check 2 carriers is have them take, baby tamoxifen for 5 years, and to do it sometime in their 30s. And we might really be able to reduce her risk back to the average person. I think that's a really important thing. And that may be something that we can now help her avoid. We would maybe screen her every year starting at 40, but maybe we could actually reduce the chance that she might ever really have to experience that breast cancer if we can apply breast cancer prevention properly. Baby TAM is, well, again, if people can take it for 5 years, we currently use it. Again, nobody knows exactly what the perfect time is. We say 5 years, and we know that at 10 years, you still get increasing benefits from having taken it. But the 5 milligram dose is really much better than the 20 milligram dose. There's still some people who just have trouble taking it at all, and we are busy trying to develop some new things that we think will be even more tolerable. But it's worth thinking. Yeah, there's just some people who just can't take it. Okay, let's do a couple more of these, and then we'll quit.
Okay, we've got Elena Rosenfeld. She's 33 years old. She's an MBA student from Boston. She learned about the wisdom study from friends. She doesn't have any personal connection with breast cancer, but she wanted to learn more about her risk and contribute to research. So she enrolled in wisdom. She's white, Ashkenazic Jewish background. Her paternal aunt and paternal great grandfather had breast cancers. She does not have a history, never had a mammogram, but when she enrolled in wisdom, she learned that she had the BRCA mutation.
So again, she's, and she learned that she was BRCA2 actually.
Oh.
So the question is, for her, she, again, knowing that you're BRCA1 or BRCA2, it's not only important to know about your breast cancer, but to know that by the time you're 40, you also have that risk of ovarian cancer risk. And so once we do recommend that women have their ovaries out and their tubes out once they've finished childbearing, to reduce the chance of getting ovarian cancer, which, by the way, also reduces the risk of breast cancer. So that's, so she's someone who could potentially take baby TAM as risk reducing, and she would also start screening every 6 months. And there are some new studies for looking at two things. One is screening every 6 months with contrast enhanced studies, either contrast enhanced mammography or MRIs every 6 months, with a way of really trying to reduce the chance that people will get their cancers detected in the node positive stage, to really keep it at stage 1.
Great. Do we have time for Charlotte?
Very quickly, let's do Charlotte. We have a minute.
Okay, Charlotte is 36 years old from Baltimore, DC. She wants to contribute to breast cancer research and advocacy after being diagnosed herself with breast cancer. She learned about the wisdom study in our Bloomberg op-ed. So she's white, non-Hispanic. She does not have a genetic mutation. She learned that because of her own clinical test after getting her diagnosis. Doesn't know her polygenic risk score because they didn't offer her that during her treatment. Maternal grandmother had breast cancer at 73. Paternal grandmother also at 65.
So Charlotte isn't eligible because she's already had breast cancer, but Charlotte's sisters and friends can join. And we hope that we'll be able to understand more about why women like Charlotte did get their breast cancers at 36. I don't want to leave the impression that breast cancer in the 30s is common, because it is not. It's much less common. But we also are trying to make sure that we are addressing this in a way that's helping us identify and the people at highest risk and to reduce their risk. That's the reason we're lowering, the age of onset for our genetic testing, to see if we can find these people at high risk and do something different for them and really change the trajectory of their outcomes, and to really give people different choices for how to screen. and to feel more confident and comfortable in the choices that they're given, because it's based on much increasingly more information. Again, not perfect, but certainly getting better, getting a lot better with time. So I'm looking in the chat to see if there are any other burning questions. We'd really love to know if this has been helpful, and what other information we can continue to provide you as we go forward. So we have one more poll for you. If you can hang in there for a few more minutes. Okay, we ready to show some results?
Hi.
Okay, polygenic risk scores. Okay, I think we should get a lot in any way to talk about it. I think getting some participant experiences would be great. And we can get Kim Badal on to talk about toxic and chemical exposures. By the way, yes, you can a wisdom advocate. You can be a wisdom advocate and a wisdom ambassador. We would love that, Danielle. I think that would be great.
I'll reach out to Danielle directly right now.
Okay, great. And I hope this was helpful. There are a lot of hard questions. Thanks for the hard questions about the screening at 74. It's a hard one to explain. And I think sometimes, someone said, oh my gosh, I got DCIS diagnosed and I was told to come in every 2 years and now I've gotten cancer. But getting DCIS, they don't have anything that's life-threatening. And, finding it early, it's like it wasn't found late at all. And so I think that this is one of the things that I'm trying to get across, is that, everything isn't the same. And, if you have a stage 1 breast cancer and it's ER positive, that the treatment outcomes are pretty much the same if it's under 2 centimeters. The big difference is if you have positive nodes. And, with the treatments getting better, what we want to do is really focus in on where we can make the biggest difference. So Christina Peterson, I'm 72 now. Will I exit the study in 2 years? Depends when you started, Christine. That's a good question, but you can always petition to move over sooner. We'll say yes. Let's see. Does the wisdom hold on to samples, and will they ever be tested for other genetic factors?
Please walk in here. It's maddening.
Someone has their mute off.
So I think that it's a good question. We do have the wisdom samples. We are trying to figure out a way so that people didn't have to do a whole nother color test to get the new polygenic SNPs. We're gonna try. I think the reason we switched the low pass whole genome is that makes it much easier, that as things change, we don't have to repeat the test and we can use it. For people who are switching over, they'll probably have to switch over and I hope people won't mind spitting in a tube. We just have to raise more money to cover it. So, that's all. So I hope you'll be willing to do that. One more message, let's see. I started in Wisdom several years ago, but I haven't had genetic testing. Yes, if you move over to Wisdom 2.0, if I were you, Kathleen, I would choose the personalized arm and get the information. That's where all the information is. I can say that. All right. Well, thanks you guys for being part of the Wisdom community, and thanks so much for your interest. And, you know, we hope we can really make a difference in screening and prevention and keep breast cancer from being the scourge that it is.
And if you haven't filled out the post-meeting survey, please let us know what you thought. I just put it in the chat again. Thank you so much, everyone, for joining us tonight.